Hello everyone, welcome back to my channel, and today we are going to talk about a very important topic from the aspect of medical school examinations as well as step 1, that is anti-arrhythmic drugs. It is the start of cardiovascular pharmacology, and this is one of the most difficult topics to understand, but we are going to start with the basic concepts and then go away to understand it in full detail. Let's start with the basic concepts. First, what you need to understand is that cardiac cells in heart tissue, there are two types of cells. One is cardiac myocytes that are actually doing the pumping or doing the function of the heart, and one are the pacemaker cells which are responsible for the automaticity of the heart. So both of these cells have different types of action potential, different graphs of action potential, and different ions that is mediating them. So what you need to understand in these diagrams and what from these diagrams is how the ions are working and for which phase which ions are working, and once we inhibit them or stimulate them, how will the action potential be altered to prevent arrhythmias or to cause arrhythmias. One thing that you need to know from the very start is that every anti-arrhythmic agent is also a pro-arrhythmic agent. It is a very confusing line, but try to understand that if a person is having a tachyarrhythmia, that means they are having high heart rate, and you give a drug that will, decrease the heart rate, so they can ultimately land into bradyarrhythmia. So every anti-arrhythmic drug is indirectly a pro-arrhythmic drug as well. Okay, so now we start with the basic concepts. The first diagram that you see here is an action potential of a cardiac myocyte. That means the cells that are performing the function. First thing that you need to remember is the basal potential, that is minus 90 millivolt. It is not minus 70 millivolt. Okay, in some cells you find it as minus 70 millivolt. We'll talk about those cells, but here it is minus 90 millivolt, and here it is in phase 4. Phase 4 is the resting phase, but what we need to talk about is the phase 0. Phase 0 is the upstroke. So in phase 4 there are no sodium channels that are open. All the sodium channels are in closed state. We are also going to talk about sodium channels, how they look and how do they work. In phase 0 there is an influx of sodium ions. So okay, if you understand that if we block sodium ion influx, so this phase 0 slope will decrease, and ultimately it will help to solve a arrhythmia. So phase 0 is maintained by rapid ion influx of sodium ions into the cells, because sodium ions are coming into the cells as they are high in the outer cell compartment. In outer compartment they are more in concentration, so they will come inside the cell. Now phase 1, it is due to chloride efflux. It is not so much important to understand this. What you need to understand is how phase 0 occurs, how phase 2 occurs, and how phase 3 occurs. Phase 0 occurs because of rapid sodium influx. Phase 2 is the plateau phase. This is known as plateau phase because there are three type of currents that are working here. Firstly, as sodium was coming in, now the sodium has stopped. Now the depolarization has been stopped. Now calcium is coming in. The calcium is coming in and potassium is going out. So a positive charge is coming in and a positive charge is going out. So they are maintained at a plateau phase. That is what you need to understand. Okay, the calcium is coming in and the potassium is going out, so ultimately there is a plateau phase that has been maintained. Okay, also there is a third type of current that works here that you need to know for a drug that will study later. There are slow sodium window currents. There are sodium window currents that are activated here. For that there is some amount of sodium that is definitely getting inside, that you need to know. Most of the people don't know about this, but there are some window currents that occur here. Now the phase 3, in phase 3 the calcium influx that was coming, due to which the plateau phase was maintained, that will stop. Only the potassium is going out. Now if the potassium is going out, the cell goes into repolarization phase. Okay, so these were the three phases that you need to understand, and you will know about these if you have studied cardiovascular physiology well in your first year. Okay, now coming to next is, these are the graphs for pacemaker cells. These are the graph for pacemaker cells, that are the cells of SA node and AV node. Okay, so now we are going to talk about this. In this is the phase 4, this is phase 0. Phase 1 and 2 are absent if you know from your physiology. and this is phase 3, and again we get to the phase 4. Now the phase 4 that you see here, it is not flat. It is not flat like here it is. It is in slightly depolarized state. Why is that? This is due to some currents. These are due to calcium currents, some T-type calcium currents, that is calcium influx, and funny channels that are actually sodium channels. Because of these, there is always a slight depolarization in these cells. That is why they are able to maintain automaticity. They are able to generate the impulse. And one important thing is here. See here. It is about minus 60 to minus 70 millivolt. The basal potential. It is not minus 90 millivolt. So remember that. In upstroke here, there is no role of sodium. As there was role of sodium here, there was role of sodium. There is no role of sodium in these cells. In phase 0, there is only role of calcium influx. There is calcium influx that is responsible for upstroke. So you will know if we will block the calcium channels for SA node, they will decrease the slope. They will decrease the slope. The slope will come like this. It will decrease. So it will take more time. So it will decrease the conduction if we block calcium channels. And you will study a type of drug classification. When we study drugs, we'll study a drug classification where there are calcium channel blockades. So they will act like this. And at that point, I will come back to this diagram. So please try to understand these diagrams right now, where which ions are working. Okay, because that is the basis of all the further chapter that we are going to study. Okay, the conduction will decrease. And for phase 3, it's again same. It is the efflux of potassium. So you needed to know these basic concepts. Okay, next we are going to come to not too much of important, but sometimes the graphs can be made. You need to understand that if this is a hole is an action potential, then this hole is APD. APD is action potential duration. Action potential duration. Okay, out of this action potential duration, till the mid of depolarization, till the repolarization, in the mid of repolarization, there is effective refractory period. What do you understand by effective refractory period? That I will teach you in the next slide. When we are in the sodium, we will understand how sodium channels work. Essentially, what you need to understand is at this point, no, so all the sodium channels are in their inactivated state. We'll study the states of sodium channels. They are in their inactivity state, so means they are not in the resting state. So if we even give an impulse, if the SA node or AV node even give the impulse till this ERP period, there will be no depolarization in these cells. In relative refractory period, some sodium channels have come back to the resting potential. They have come back to resting state. So if we give a sufficient enough high potential and high stimulus, they will be excited and they will produce a next graph. Okay, so let's understand about sodium channels, how sodium channels work. So in sodium channels, actually there are two types of gate. There is an M gate and there is an H gate. It's a very good diagram that I have taken from Kaplan, that M gate in this resting state, M gate is closed and H gate is open. You need to understand this. M gate is closed and H gate is open. So effectively there is no sodium ions that can come inside because the M gate is closed. So the channels are essentially closed. So the conductance of sodium, the G sodium, is essentially zero. Okay. Once we reach the threshold, the M channel will open. M channel will open. Ultimately, the sodium channels are open. So now they are in their active state. They are in their active state and not in their resting state. Once they are in their active state, the sodium influx will occur. That was responsible for the upstroke. That was responsible for the phase 0. That phase we were talking about. In phase 4, the sodium channels were in the resting state. Once they got a threshold, they gave the upstroke. There was influx of sodium. Influx of sodium. And while there was influx of sodium, the H gate started closing. H gate started closing, and ultimately the H gate will close. Once the H gate closes, now the sodium channels are in their inactivated state. What do you mean by inactivity state? The M channel is open, but H channel is closed. So even if you give an impulse, there will be no excitation. That is what I was talking about here. At this point, all the sodium channels are in their inactivated state till this point. After this to this, they are in their inactivated state. So even if we give an impulse, the H gate is closed. They will not be able to get excited. But after ERP till RRP, the sodium channels are getting back to their resting state. So if we give a very high stimulus, they will get excited. That is what you needed to understand. And here only understand how the classes of drugs will act on sodium channels. There are three classes of drugs that act on sodium channels. That is 1A, 1B, and 1C. 1A acts on active channels, active. 1B acts on these inactivated channels, and 1C acts on these resting channels. Okay, so you need to understand this. Next, let's come to what are the commonly encountered arrhythmias. You just need to know some names in case somebody asks you these in Viva, or you get a question about elaborate the different types of arrhythmias that are there. There are atrial arrhythmias in which there is atrial flutter and atrial fibrillation. There are supraventricular tachycardias that the ectopic foci is superior to the ventriculus, and there are ventricular tachycardias where we have acute ventricular tachycardia as well as we have ventricular fibrillation. Okay, so now coming to the classification book. This is one of the most important pages that you have to learn. If you learn this, you at least have a bit of something to write in your exam. But if you are targeting for step 1, you have to know about each of these drugs in detail that we are going to study further. So there is class 1 drug, class 2 drug, class 3 drug, and class 4 drugs. Class 1 drugs are sodium channel blockers. These are sodium channel blockers, and they are further divided into 1A, 1B, and 1C. And we have just yet studied that how they act. 1A acts on activated sodium channels, 1B acts on inactivated sodium channels, and 1C acts on resting sodium channels. Okay, the class 2 of drugs is the beta blockers. As we are studying heart, there is obviously autonomic nervous system that is going to come here. So we have beta blockers. Class 3, we have potassium channel blockers. As we know, potassium is responsible for repolarization. In class 4, we have calcium channel blockers, which is responsible for plateau-phase in cardiac myocytes and upstroke in the pacemaker cells. So that is why you needed to know about all these ions. You needed to know about sodium, you needed to know about potassium, you needed to know about calcium, because we are blocking them ultimately. So what effect they will produce, that depends upon how better you have understood your basic concepts. Okay, so coming to class 1A drugs, they're activated sodium channel blockers. They're blocking the sodium channels that are in their activated form. That means M gate is open and H gate is open. Also, an additional property of 1A drugs is that they can block potassium channel as well. That is their additional property. And now, just listen. If this was potassium channel graph, that this was the graph, a rough graph. This was potassium channel and this was potassium channel. If you are blocking potassium channel and you are blocking sodium channel, you are going to affect it all of these. If you are affecting sodium, if you are affecting potassium, you are affecting almost all of the phases. So ultimately, what your graph will look like will be a decrease in slope and an increase in. So this is, you see, this will be the change that you see. There will be decrease in in upstroke, and there will be increased duration of repolarization. As you are blocking the potassium channel, this will increase the action potential duration. So what the action potential duration that was this suddenly became this. So APD will increase. Okay, you needed to understand this. Next, we come to drugs. Drugs, I have highlighted in each of the section. I have highlighted the drugs which are much more important and much more popular in step exams, as well as which are much more likely to be asked in your med school exams. Drugs like quinidine, procainamide, and disopyramide. You have to remember quinidine and procainamide. We are going to have a in-depth discussion about these. So coming to quinidine, it will decreases the slope of phase 4 spontaneous depolarization. Okay, that we we have to talk about this, how this is causing that. It is causing that because of muscarinic receptor blockade. It has an essential property of muscarinic receptor blockade as well as alpha receptor blockade. So because of these, what will happen? Let's see. If you are blocking muscarinic receptors, if you are blocking muscarinic receptors, they're essentially causing sympathetic stimulation. They are causing sympathetic stimulation that will ultimately increase your heart rate and AV nodal conduction. For some people, that would not be so good. So, in case of tachyarrhythmias, they can be kind of dangerous. Okay, if you give quinidine in tachyarrhythmias, they will be dangerous because they are blocking muscarinic receptors. Okay, so that will cause ultimately sympathetic stimulation. Now you will read that there is also alpha receptor blockade. So people will think there is blockage of alpha receptors, so it is good to give it in sympathetic stimulation. No, it's not good. If there will be blockade of alpha receptors, there will be ultimately hypertension. And if there will be hypertension, there will be reflex tachycardia. So you have to understand that there will be a reflex tachycardia that will happen here. That is a very important point to understand, that reflex tachycardia will be seen when you will give quinidine. While quinidine is rarely used because of its adverse effects. And what are its adverse effects? It's known as synchronism. Why do we call it as synchronism? It's a very, synchronism word can be your hit word to identify the drug in any MCQ. In MCQ, you find characters like synchronism, and you can easily be sure that the drug we are giving is quinidine or we are dealing with antiarrhythmic agents. So why do we name it as synchronism? Is quinidine kind of sounds like quinine. And quinine is an anti-malarial drug. And quinine is actually derived from a bark of a tree that is known as the cinchona tree. That is why its adverse effects are known as synchronism, which are blurred vision, tinnitus, or disorientation. Now, due to its alpha receptor blockage, there will be hypertension. Okay, and because it's causing increase heart rate and AV nodal conduction, there will be prolongation of QRS and QT interval. So you needed to know about this. Drug interactions are common as quinidine is an inhibitor of CYP2D6. So you have to know about the drugs which you are giving, combining it with, that they are not metabolized by CYP2D6. And it can also cause toxicity of digoxin by displacing it from tissue binding sites. So ultimately, if you are giving quinidine with digoxin, it will displace it from tissue binding sites and will cause toxicity of digoxin, which is not good for heart. As digoxin is also a pro-arrhythmic agent as well as an anti-arrhythmic agent, and it actually blocks sodium potassium ATPase channels. So we cannot cause toxicity of digoxin. Okay, coming to next drug, that is procainamide. Procainamide, unlike quinidine, has no alpha blockage. So there will be no reflex tachycardia that you will see. Okay, there is muscarinic receptor blockage, but there is less. There is less muscarinic receptor blockage, and it is only available in IV formulation. Can be used in emergencies. Also, procainamide is eliminated by a kidney. So, if it's eliminated by a kidney, the patient, if there is any renal dysfunction or any acute renal failure, the dose should be adjusted for procainamide. Its adverse effects, very important, is SLE-like syndrome. So, give you a picture like systemic lupus erythematosus, and there will be hematotoxicity. Hematotoxicity, what you will see, thrombocytopenia or agranulocytosis. So agranulocytosis is one of the most common side effects that you can see, and procainamide is one of the drugs which causes it, so you need to know it. Okay, now coming to class 1B drugs that we know actually block inactivated sodium channel blockers. So because they block inactivated sodium channel blockers, they are known as fast sodium channel blockers. Fast sodium channel blockers. Okay, because they're already in their inactivated state and you are blocking them further, so there's very fast blockade. Okay, they are preferentially for the tissues that are partly depolarized. Why? Because we have already told, when you will get sodium channels that are inactivated, when there will be depolarization. Once there is depolarization, only then the cells turn into depolarized state, so sodium channel will only then be in its inactivated state. Now there is decrease in action potential duration because of 1B drugs. This is very important. Why there is decrease in action potential due to 1B drugs? So let's make a diagram here. There is decrease in action. See, they are blocking sodium channels, so there will be an decrease in slope. But here there is decrease. Now this decrease here, it occurred due to blockage of sodium window currents. I already told you three types of currents that are responsible for phase 2 plateau graph. One was calcium influx, one was potassium efflux, and one was slow sodium window currents. So because of these blockade of sodium window currents, this will shorten the phase 3. Okay, so that was important. And which is the one of the most important drugs that you need to know about 1B, that is lidocaine. Mexiletine is also there, but lidocaine you need to know. Okay, coming to lidocaine and mexiletine, they can be used in ventricular tachycardias and ventricular fibrillation because they are decreasing action potential duration and decreasing the slope of phase 0. They are given, lidocaine is given intravenously while mexiletine is given in oral formulation. You need to know this. This is important. Lidocaine is only given intravenously. Why? Because of its high first pass metabolism. Lidocaine has very high first pass metabolism. That is why it is given intravenously. Lidocaine has a fairly wide therapeutic index, so it not needs to be monitored too closely. But mexiletine in oral formulation has a narrow therapeutic index, so it needs to be maintained. You need to do ECG. You need to keep a check on a patient that the drug is not causing toxicity. Okay. Adverse effects of lidocaine is CNS toxicity. The most common word that you will find in a question stem is nystagmus. If you find nystagmus and CNS toxicity related to a heart patient, a person is most likely to be on lidocaine. Okay, but why is lidocaine preferred is because it's least cardiotoxic of all the conventional antiarrhythmics. I already told that all the antiarrhythmics are pro-arrhythmogenic as well, but lidocaine is the least cardiotoxic of all the conventional antiarrhythmics, and this can be a very common general MCQs in university exams, not in step one, but in general university exams. Coming to next, class 1C, that blocks the resting state sodium channels. When they block resting state sodium channels, there is no effect on APD. You'll think why there is no effect on APD, you know, because once if they are, understand this. Okay. If there is decrease in this graph, there is also this. Okay, there is a little bit of effect on potassium channels as well. So when there is blockade of sodium channels, that results in decrease in the slope of phase 0. There is also a change in phase 4. Okay, phase 4 is also shortened due to potassium channels, and that ultimately makes APDS same. So that can be a very important thing to know. There is no effect on action potential duration. Okay, the drugs that you need to know is flecainide. Propafenone also you can remember, but flecainide you need to remember. Okay, so flecainide, there is limited use because of pro-arrhythmogenicity. It's highly pro-arrhythmogenic, so that is why there is limited use. Also, you can see there was a point here that due to negative ionotropy, these are not used in patients with structural heart diseases like ventricular hypertrophy, left ventricular hypertrophy, restrictive cardiomyopathies. In that, class 1C drugs are not used because of negative ionotropy. And why do they have negative ionotropy? Because of weak beta blocking property. And we know what beta blockers do. If you block beta, ultimately beta 1 blockade will decrease CAMP and will lead to negative ionotropy. Okay, these are metabolized by CYP2D6. You remember quinidine? If you give quinidine and flecainide together, what will happen? Let's see how much do you remember. If you give quinidine and flecainide, although never give them, but if you give, what will happen? There will be toxicity of flecainide, because quinidine is an inhibitor of CYP2D6. So that is why it's important to know about which are inhibitors and which drugs are working via CYP mechanisms, which CYP enzymes. Okay, so this is an important thing. Quinidine and flecainide. Okay, so last point is that only should be used with caution with potent inhibitors of CYP2D6 like quinidine. Okay, now coming to next drug, that is class 2, that is beta blockers. Beta blockers, what will they do? They will act on pacemaker tissue. Pacemaker tissue. Remember pacemaker tissue diagram? This phase 4 spontaneous depolarization, phase 0 due to calcium currents, phase 3 1 and 2 and absent. So beta blockers will act on this phase 4. Once they block beta, once you block beta, there will be prolongation, prolongation of phase 4 prolongation, that will ultimately lead to decrease SA nodal and AV nodal activity. So that is what the next point is, that they decrease the slope of phase 4 of action potential in pacemaker tissue, and they are useful in treating tachyarrhythmias. Okay. What are the drugs? Non-selectively metoprolol and propranolol. And if you have to see cardioselective drugs, that is acebutolol and esmolol. Esmolol plays an important role when it is given IV. Esmolol IV is used in acute supraventricular tachycardias. So that is one important point to remember, that esmolol IV is used in acute supraventricular tachycardias. Can be very commonly given to you that what is a drug that can be used for acute supraventricular tachycardias, that is esmolol IV. Okay, what are adverse effects? That are general adverse effects of beta blockers, that is hypotension, bradycardia, and fatigue. Okay, coming to class 3 drugs. So, okay, class 3 drugs, the first drug is amiodarone. It's one of the most important drugs that you need to learn in this whole chapter after quinidine and lidocaine. One of the most important is amiodarone. It is a potassium channel blocker. It is a potassium channel blocker. Okay, and it is iodo. You are getting from its name, iode contains iodine. Okay, it's a potassium channel blocker and also shows alpha blockade. So it has a potential for reflex tachycardia. It has a potential for reflex tachycardia. Okay. But one of the most important point is it shows property of all the classes, class 1, 2, 3, and 4. Actually, it shows property of all these classes. One of the most important points, a drug showing activity of all the classes. It shows sodium blockade, it shows potassium blockade, yeah, it shows calcium blockade. It has every effect. Okay, that is one of the most important points that you need to learn. And it will increase APD and ERP. How? Let's once again understand. If it's blocking potassium channels, attacking potassium channels, so ultimately there will be increase, there will be delayed phase 4 phase 3 repolarization, there will be increase in APD, and ultimately ERP is effective refractory period. What you need to know more about is that it binds extensively to the tissue. It has a very large volume of distribution. Okay, the major disbenefit of amiodarone is its half-life. Its half-life is about 80 days. Do you think it can be used as a potential drug? It can be highly used. No, it cannot be, because remember from your general pharmacology, how many half-lives does it require to reach steady state? It requires about 3 to 4 minimum half-lives to reach steady state. Here, 3 to 4 half-lives would mean like 240 days, many months. Okay, so 240 to 250 days is like a lot of days to reach steady concentration. That is why amiodarone is not such use, especially not in acute conditions at all, because of its very long half-life. And you need to know about its adverse effects. Major adverse effects are on lungs, like pneumonitis and pulmonary fibrosis. One major important is due to iodine, that is blue-gray skin pigmentation. One interesting point that I have learned is that how you can correlate this blue gray skin pigmentation is that take a potato, you know, take a potato, just peel its skin and apply some betadine or some iodine ointment on it, and you will see a very dark purplish and bluish discoloration. That is actually the discoloration that you see in these patients. Okay. And there is thyroid dysfunction. Why thyroid dysfunction? Because of iodine. We know that iodine itself acts as an inhibitor for thyroid, so there will be thyroid dysfunction. There can be hypothyroidism or there can be hyperthyroidism, but there is thyroid dysfunction. That is what you will need to know about amiodarone. It's a very important class of drug that you need to know. Next, coming to another class 3 drug, that is sotalol. Sotalol, from its name, can be given. It's also a beta blocker. And yes, it is. It is non-selective beta blocker properties there. So ultimately, because of beta blocking property, there will be decrease in heart rate and AV nodal conduction. But because of this heart rate and AV nodal conduction and beta blocking property, there is a side effect called torsades. Torsades is when you are only finding QRS complexes. There is QT prolongation. Okay, so very important side effect of sotalol is torsades. Okay, other class 2 drugs that you can know about is one you need to know the name of is dronedarone. Dronedarone. There is dofetilide and ibutylide, but you don't need to remember the names of those as such. But do need know about dronedarone, sotalol, and amiodarone. Okay, coming to class 4 or last category of drugs before we move to unclassified drugs, that is calcium channel blockers. And the calcium channel blockers that we have here is the non-DHP. Why? If you use DHP, they will block calcium channels in vessels as well, due to which there will be hypotension and ultimately reflex tachycardia. That is why we use non-DHP, non-dihydropyridine calcium channel blockers, and that is verapamil and diltiazem. Please remember these names, very important. They will come in our further chapters and we talk about antihypertensives, But DHPs are not used, the hydropyridines, the drugs known as the dipene kind of drugs, nifedipine, amlodipine, these are not used here. Okay, so this is a point that you need to learn. Non-DHP calcium channel blockers, verapamil and diltiazem. And what will they do? As they are working on calcium channels, they will act on phase 0 and phase 4 of pacemaker tissue. Remember again this diagram, here phase 4 and here phase 0, both had calcium channels. So once you block them, you actually make a diagram like this. Okay, there will be prolongation of phase 4 as well as prolongation of phase 0. Okay, so there will be decrease in phase 0 and phase 4 slopes and increase in their duration. Okay, there will be decreased S nodal and AV nodal activity because of this prolongation of phase 0 and phase 4. The use is supraventricular tachycardias. Another drug. Do you remember an IV formulation of a drug that is used in acute supraventricular tachycardia? Which drug did we study? Esmolol. If you remembered it, that was good. Esmolol, just studied it. Okay. What will be the adverse effects? Adverse effects will be bradycardia, hypertension due to calcium channel blockade, and peripheral edema. One of the most characteristic side effects of calcium channel blockade, peripheral edema. Also, these drugs are eliminated via hepatic sites, so that is why those need to be adjusted in patients with hepatic dysfunction. And also, again, like quinidine, they will displace digoxin from tissue binding sites. Okay, like quinidine. Two drugs do this, quinidine and calcium channel blockers. They will displace digoxin from tissue binding sites. Okay. Next, coming to unclassified drugs. Unclassified drugs, you have digoxin, which is actually a sodium potassium ATPase blocker. It can be used. Okay. Adenosine, one of the most important drugs that you need to know about from these chapters. It's unclassified. It has adenosine receptors. These receptors are GI coupled. What you need to know is they are GI coupled. Because they are GI coupled, they will decrease the S nodal and AV nodal activity, and that is why these are drug of choice for paroxysmal supraventricular tachycardias. So we have studied about the drugs for supraventricular tachycardias just right now. Okay, supraventricular tachycardias, we studied IV esmolol, we studied calcium channel blockers, CCBs, non-DHP, and we have just studied the drug of choice, that is adenosine. Please remember, adenosine is drug of choice for supraventricular paroxysmal tachycardias. It has a half-life of just 10 seconds of half-life, so it's very rapidly acting. Okay, and it is antagonized by methylxanthines. Why? We have just studied that they decrease S nodal and AV nodal activity, means they are decreasing sympathetic stimulation. They are decreasing sympathetic stimulation. While we know the drugs in methylxanthines like theophylline and caffeine, they cause alertness. They increase the sympathetic stimulation. So that is why they are in adenosine is antagonized by methylxanthine. This is one of the important points that can be used on a question stem in your exams, and especially on USMLE step 1. They are antagonized by methylxanthines. Lastly, what you need to know is a drug of choice for Torsades de Pointes. Do you remember a drug that can cause Torsades de Pointes that we just studied right now? Yes, sotalol. We had a side effect of Torsades de Pointes. So now the drug that is used to correct this is magnesium sulfate. This is drug of choice for Torsades de Pointes. And lastly, drug which you don't need too much remember except for just writing in your exams, ranolazine. Okay. So that's it, guys. That was it for this video. It was a very long video, but a very, very important topic as well. So lastly, if you liked my video, please like the video, subscribe to the channel, press the bell icon, and please follow my Instagram page, MedPath with Piyush at Instagram. I will also be posting questions regarding to antiarrhythmics very soon. Once you see this video, it will be coming in a day or two. We have a rapid question session where we have 5 to 10 questions on antiarrhythmics. Okay, and also please do tell me which method you like better, like the way I teach before by writing the notes, or like this by making a PPT and then presenting it and teaching on it. Which method you like more better? If you will need this PPT, you can just comment down and I'll send you the PPT, or I'll just upload it somewhere and then give the link in the description. So that was it for today, guys. Thank you for joining. We'll meet in the next video of cardiovascular pharmacology with antihypertensives. Thank you.